Hi, everyone. Thanks for joining us. We are super excited to talk through a case with you all.
I think Shema has a couple backup cases that she promises are not esoteric, but I am reminded that esoteric is a relative term. So things that are not esoteric to Shema does not necessarily mean that they will not be esoteric to Charmaine and I. But if anyone has a case, please feel free to let us know. Otherwise, we'll kick it over to you, Shema, to get us started this morning. All right, I counted to 7. Shema, take it away.
Okay, so starting with the first aliquot, we have a 41-year-old female who is presenting with chest pain, cough, shortness of breath for a duration of 1 month that has worsened over 2 weeks. And the pain itself was described as pressure-like, intermittent, non-exertional, non-radiating, and it was worse with leaning forward. Her symptoms also included intermittent palpitations, poor appetite, decreased exercise tolerance, and an inability to sleep on her right side. And I would stop here.
All right, what a start. Thanks so much, Shema. So we have a 44-year-old who is coming in with this 1-month history of kind of sounds like perhaps pressure-like, maybe there's some component of pleuritic chest pain there with cough and shortness of breath that has just gotten worse. I think when you think about the things that I meant from that I mentioned from chest pain to shortness of breath to cough, chest pain is always the one that grabs our attention first. And even though she's having 1 month of symptoms, I think still is always a good idea to think about your misdiagnoses, especially when it comes to chest pain. And, we love our 4+2+2 mnemonics with cardiac being ACS, aortic dissection, tamponade, and then attack-classical cardiomyopathy, 2 being pulmonary, embolism and pneumothorax, and 2 being 2 esophageal causes of rupture and impaction. That being said, with the component of cough, shortness of breath, you also want to think about more about like pulmonary causes, whether anything that causes pleuritis that would allow for the sensation of chest pain, and that is like worse leaning forward, or kind of like something like pericarditis, thinking about irritations that can lead to a pressure-like sensation that is accompanied by shortness of breath and cough. I'll stop there and then pass the mic to Jack for additional thoughts.
No, I think I am right there with you in terms of contending with both the cardiac and the pulmonary causes. And like the syndrome is one where our brain goes over into the cardiac causes first, at least in terms of the acute clinical problem. But these other dimensions of it that you mentioned, like the cough, the dyspnea on exertion, the worst one lying on the right side, brings the lungs into it. And I'll just kind of talk briefly about the time course here, because I think we have sort of two features that are helpful about the time course. One is the duration, but the other one is the trajectory of the illness. And the duration that we have is one that's been happening over, exactly as Charmaine mentioned, a subacute period of time. And then the trajectory is one in which we sort of have what seems to be some sort of crescendoing illness. And if we think about what types of disease processes can crescendo in this way, there's a couple ways that this can happen. One is we can think about infectious or indolent infectious diseases that may then end up crescendoing because as the disease progresses, the symptom burden gets higher. Autoimmune diseases can also oftentimes smolder along, and then they might flare in some capacity, and that can also lead to a crescendoing presentation. And then certain malignancies can also crescendo in nature, because malignancies may, for example, be a space-occupying process. And that space-occupying process can cross a certain threshold where the space that is being occupied goes from leading to mild symptoms to more significant and severe symptoms. And so if we think about, well, what are the potential disease entities that we just mentioned that may manifest in the thoracic cavity, like Charmaine mentioned, right? If we think about infections, there's certainly pulmonary and pleural infections that can do it. malignancies, we would probably turn our attention in a younger individual who, at least at this point, that we know doesn't necessarily have risk factors of lung cancer, but that may change. We might focus our attention on what's happening in the mediastinum, right? Place where there could be oftentimes lymph nodes that could be enlarged from underlying or lymphoproliferative disorders, or less commonly in a 41-year-old, a solid organ process that has made its way to the mediastinum. And then there's a whole host of autoimmune diseases, most characteristically sarcoid, that can also cause mediastinal disease. And so I think that's one way to potentially map the overlap of these symptoms, is to say that seems like the lungs are on the hook, but maybe also the cardiac structure are on the hook, and the mediastinum could be a place where we could see the disease centering. And I think, again, thinking about those crescendoing illnesses, again, indolent infections, autoimmune diseases like sarcoid, or space occupying malignancies would be one way to have this sort of trajectory present.
Amazing. So I would give you more information. So to her past medical history, it was only significant for right retinal vein occlusion. That was 9 years prior in the setting of oral contraceptive use. She also got a thrombophilia workup at that time that was negative. She is originally from Mexico and moved to the United States 19 years prior. She's working at a restaurant, and she didn't smoke or drink or use any recreational drugs. She denied any personal or family history of autoimmune disorders. She also denied any family history of cancer. And and at the time of presentation, she was also up to date on appropriate cancer screening. And before information, I would stop here, so to see whether anything changes your differential.
Yeah, so I will just reflect briefly on some of the elements of the social history here. I think oftentimes in any clinical reasoning or clinical problem solving exercise like this, when we see an individual who is from a geographic area in which some of these indolent infections are endemic, our brain may just go on a speedway and say, we have to think about diseases like TB and other infections that may be endemic to Central and South America. And I think it's important to not only just look at the where, but also look at the when, because we see that I think she moved. I think what I heard from you, Shema, is that this is somebody who moved to the United States 19 years ago, which is a quite long time. And I highlight that point because I think we're always at risk when we make these quick heuristic associations. We're always at risk at perpetuating stereotypes when we make these sort of quick associations. Like we see somebody is from Central and South America, and immediately we jump to thinking about TB and these other infections that may be endemic to the area. And while it's important to think about those, it's important to be rooted in epidemiology when we think about this. And if these infections occupy too much space in our mind, we may miss far more common and far more morbid considerations, like the ones that Charmaine mentioned in the first aliquot. And so I think it's important to recognize not just the where, but also the when. Most individuals who move from an area where some of these underlying mycobacterial or fungal infections may be endemic will see disease flare most often within the first 3 to 5 years after that move. Now that's much different than the 19 years that we have here. There's a couple other times where a distant history will lead to these diseases flaring, and that's in the setting of new immunocompromise, either from an acquired infection like HIV or from the development of an underlying malignancy that leads to immunocompromise and reactivation of some of these old indolent infections. And so seeing that she is previously lived in Mexico and moved 19 years ago, what I'm doing is I'm noting that, and I'm actually making a cognitive effort to push it to the back of my mind for now, because probabilistically, many of these other much more common diseases that we just talked about deserve more attention from us, both because of their probabilistic likelihood, but also because of the fact that we want to be attuned to the reality that we're always at risk of perpetuating these types of stereotypes when we make those quick, fast, sort of type 1 thinking conclusion. So I'm using that as a trigger to slow down the thought process and really ask how much cognitive energy does it deserve? And I think at this time, it deserves a note, but not necessarily a paragraph in our reasoning. Charmaine, what are your thoughts?
Beautiful, friends. I got nothing to add.
So now I will give you more information. So she was mildly overweight, and to her vitals, the vitals on admission were unremarkable. The only exception was her O2 set of 94%, but otherwise she was not in no acute distress. The only the only pertinent physical exam finding was a decreased breath sound in the right middle and right lower lung fields. And then she also got a chest x-ray that revealed an opacification of the right middle and lower lung fields. And she was also we were taking some sputum samples in order to rule out TB, and all the three were negative. And then she also got a CT angiography of the chest that showed a large right-sided pleural effusion with right-sided compressive atelectasis and mediastinal shift to the left. And there was also a slightly lobular posterior pleural thickening on the right. Yeah, I would stop here.
All right. Thanks so much, Shema. Again, vital signs are vitals. Thankful patients like starting 94% on room air. So we have a little bit of time to think through this case. And the other thing that I would always recommend doing, just making sure, especially people with underlying if you're concerned about underlying lungs, is to do an ambulatory sat to make sure to walk the patient to see how they're satting. And a lot of these patients tend to become a little bit more hypoxemic when they are walking. In terms of like the exam, then, right off the bat, then we become our focus shifts to the pulmonary system, given the opacification and also the decreased breath sounds on the right. And as you were giving us more story, Shema, I was like thinking, I was like, middle and lower lobe, could this be, like a multifocal pneumonia? Is it atelectasis? What is going on? So more information with the CT scan is actually quite helpful to see what is going on. So, with that pleural effusion, we need to do a thoracentesis to get some more information. Because, most likely in this case, I would bet am I a betting person? I don't know about that, but I would worry about this as an exudative process. I given how she's been feeling over the past few months. However, any large pleural effusion that can cause atelectasis, and which we are partially concerned about here, could lead to dyspnea on exertion. I suspect a lot of the time pleural effusions wouldn't cause kind of pleuritic chest pain. So with that thickening, I'm worried about pleuritis and a kind of inflammatory process that is going on. The other thing to also think about, although we haven't seen anything, is there any like post-obstructive like pneumonia that is going on, anything that's atelectatic, it might not be clearing as well. So if there's any component of an infection that is going on there. With the TB sputum rollouts, usually we have good sensitivity for it. And again, like this is not how my illness script for an active TB. However, TB can do whatever it wants to do. And with the 3 negative sputum, I think it is reassuring that, however, if it's hiding under pleural fluids, you might not be able to catch it as well. Jack, what thoughts do you have?
I think that analysis was just absolutely brilliant. I'll just sort of riff a brief last point that you mentioned, because I will humbly eat my words from the soapbox from the last aliquot and say that now the calculus changes a little bit. And exactly as you mentioned, I think we have a good, at least a very high probability that it's an exudative effusion based off of the imaging findings. And now that we have a large suspected isolated exudative effusion, then certainly right now is the time to bring some of those more indolent infections back into the fold, particularly if we confirm that it is an exudative effusion, and if we see some other characteristic features, which we may be able to talk about later. But I think the point that you mentioned about how do we contend with the 3 negative sputum samples is I completely agree with you. I think it does decrease the probability of pulmonary tuberculosis with a coexisting parapneumonic effusion or an ipsilateral parapneumonic effusion significantly, but it doesn't necessarily rule it out because pleural TB is actually extrapulmonary TB, not a complication of pulmonary TB. So if you think about tuberculosis in general, we can have pulmonary disease, which is usually either the classic cavitary lesions or consolidations that we may see. But then there's extrapulmonary TB, and that involves things like scrofula, right, or TB lymphadenitis. We may see disseminated lymphadenopathy, or we may see disease in other organ systems. And when you have it involved in the pleura, that individual has moved to having disseminated extrapulmonary tuberculosis. So it's possible, it's rare but possible for someone to have TB only in the pleural space and not in the lungs. And so I think again I think the probability goes down substantially, but it certainly is not zero at this point. Both given how difficult TB can be to diagnose from sputum, even if it is there in the lungs, but also given the fact that it can be in the pleura and not be in the lungs. And then I think the only other point just to double down on is what you mentioned about whether or not we can frame this as a pleural effusion with no lung pathology or a pleural effusion with obscured lung pathology. Because certainly within the atelectatic area, but both from compression from the effusion and whatever process may be hidden in the lungs, right? As that lung re-expands, opens up, it may expand and reveal to us pathology that's hiding there in that space. And so I think I'm contending right now with framing this as, is this an isolated pleural process, or is this a pleural pulmonary process where the pulmonary stuff is just hidden at this point? Though that becomes helpful because we can sort of use our pleural mass or our pleural nodule or our lung cavity DDX, depending on what may be hiding, if we find that it's a pleural pulmonary process, whereas isolated pleural disease shifts a little bit more towards these disseminated infections, autoinflammatory disease, like you mentioned, Charmaine, with pleuritis, and then potentially sometimes malignancy as well.
Awesome. So for the next aliquot, I would also put it in the chat to make it easier. So, okay, so she got a chest tube and it was draining 2,400 milliliters of serosanguinous fluid over 72 hours. And the white blood count was 1,200 and 95% lymphocytes. pH was 7.413. Creatinine 0.66, glucose 93, amylase 38, LDH 358, protein 5, triglycerides 41, ADA was within normal limits. And there was, we also did pleural fluid culture that showed few polymorphonuclear leukocytes, no organisms, no fungal growth, no acid-fast bacilli. And then afterwards, we again did a non-contrast chest CT after the drainage, and it showed a resolution of the pleural effusion and revealed multiple diffuse nodules in the right lung, parenchymal versus pleural-based with irregular paraspinal pleural thickening. And yeah, I would stop here.
This is me as I take a bite. All right. So let's talk through it. So we have both new imaging findings and new pleural fluid findings. I'll talk briefly about the imaging findings really quick because I think some of these things here are actually something we may not commonly see. So let me just pull up something related to nodular pleural thickening. Give me 1 second for us to understand kind of what exactly to do with this finding. Right, so the imaging has newly revealed to us that there is maybe some focal pleural thickening. David, do you mind if I take over the screen really fast? Okay, let me just do this really quick. Okay, so whenever we see the finding of pleural nodularity, right? We can again sort of break this down into the very common disease categories that we see, right? Malignancy, infection, and some others like sarcoid, rheumatoid arthritis, etc. In terms of thinking about the journey that we take through exploring this, the journey is going to start with looking for disease in the chest, exactly as we did, right? The most common thing being malignancy, right? So we want to look for lung cancer and ask ourselves, could these findings in the lungs represent lung cancer, right? Whether that's adeno or squamous or mets that have made their way to the thoracic cavity, most commonly breast, as well as ovarian and melanoma. We look at this individual, right? We don't necessarily see prominent risk factors for lung cancer, but it's important to note that breast cancer is oftentimes at least a CT negative malignancy. So the possibility of breast cancer that has metastasized to the pleura, causing this pleural nodularity and this large lymphocytic effusion is certainly on the table. We get isolated pleural malignancies, usually mesothelioma associated with asbestos exposure, which we don't necessarily see here. And then certainly there's hematologic malignancies that can do it, most notably lymphomas. And this could be an extranodal manifestation of a lymphoma, or you can have primary pleural or primary effusion lymphoma, which is super rare. So one we won't necessarily consider yet on this. And then the other things that can do it, like we said, are infections like TB, other endemic fungal infections like Cryptococcus, and then some of these rheumatologic diseases like sarcoid and rheumatoid arthritis. And then there are less common, but certainly possible things in individuals who are at risk for endometriosis, like thoracic endometriosis, that can also come here. So I think what this helps us do is then give us a framework to think about, okay, how do we interpret the things from the pleural fluid on top of this and start to weigh whether or not it looks like we're dealing with a malignancy or whether or not it looks like we're dealing with an infection. Although again, for these infections that we're considering, the overlap can be quite challenging. But I think this is one way for us to think through the pleural nodularity. Again, prioritizing underlying solid organ cancer, thinking about the rare cause of pleural cancers and heme malignancies, and then also again holding the possibility of an underlying infection in our back pocket as well. Jeremy, I'll kick it to you for the pleural fluid.
Beautiful. Yeah, and I agree totally with Robbie and Austin, who also put this in the chat that, the degree of lymphocytes in the pleural fluids makes me really worried about either a malignancy here or TB. And, that's why you never really exclude TB until you have a biopsy. And I think especially with, if I remember correctly, with pleural effusions, like culture doesn't have a good sensitivity for TB. So a lot of the time, if you're worried about pleuritis, you have to get a biopsy. So that is kind of a big question here, to be able to get a biopsy to be able to definitely rule out TB. As again, it affects the treatments. So I think malignancy versus TB is where my mind is at right now.
Amazing discussion. So I would now reveal more from the pathology side. So and we also did some CT scan of the abdomen and pelvis to look for a clear primary, but we didn't identify anything like this. And then we did some PET CT, and it showed metabolically active pleural-based masses in the right hemithorax and nodular masses in the right lung, with mediastinal and retrocrural and retrocaval lymphadenopathy concerning for malignancy, metastatic disease. And we did some cytological studies and of the pleural fluid that reveal, so the cytological studies of the pleural fluid reveal what were thought to be gland-forming malignant cells. They were positive for CK5, CK6. We were negative for CK7, CK20, TTF1, CEA, calretinin, and some other ones. I will put it in the chat. And then we did a tissue biopsy with ultrasound-guided transbronchial sampling. And the biopsy showed fragments of fibrous tissue and fragments of cytologically bland cells that were positive for chylretinine and CK5-6, focally positive for CK7, and negative for TTF1 and other markers. And so before giving something, before revealing the final diagnosis, does it give you a hint? Yeah.
Nope. What about you, Jack? I was
No,
like,
I mean,
time to Google.
Okay, I will
yeah.
now reveal.
I mean, I think I would just say the closest, like all of the abbreviations, I don't know. The one thing that like sort of sits a neuron in my head is the idea of gland forming cells, like thinking an adenocarcinoma. And then just goes back to like, well, where can adenocarcinomas come from? They can come from GI or pancreatic tissue, and they can come from breast tissue, and they can come from lung tissue as well. Like those are the places that I usually associate adenocarcinomas with, in addition to in individuals who have the prostate. And so I think if we chip those away, the ability of breast cancer goes up. But that's by virtue of epidemiology and gland forming, as opposed to any of those tumor markers, which was this completely over my head. But I'm very relieved that we have colleagues who have the expertise to interpret them.
I know, love. We have oncologists, and yeah, I think Austin and Yas also agree that it might be breast cancer. So Shema, teach us.
So these findings were considered to be consistent with mesothelial origin. And then we did a CT-guided biopsy of the right-sided pleural tissue that demonstrated poorly differentiated carcinoma morphology with necrosis and an immunostaining profile consistent with a diagnosis of malignant pleural mesothelioma. So based on the findings on pathology, she was then diagnosed with malignant pleural mesothelioma of an epithelioid type with malignant effusion, multiple pleural nodules, and mediastinal and retrocrural lymphadenopathy. And now, as you asked, did she have any other risk factors? So due to these findings, she was asked for any prior risk factors, and she reported that around 18 years ago, she her apartment had construction in 3 of the 5 rooms, and she would clean up after the workers were done. She also asked her landlord at the time to be relocated, but the landlord denied her request, and she had a similar situation also 2 years ago, but she was again denied relocation. So yeah, it was maybe due to asbestos exposure. And some pathology notes from my studying, CK5, 6, and chylretinine are typical for mesothelioma, as I learned. And as far as I remember, CK20 is a marker that is typical for GI tumors, and CK7 more for tumors that are above the diaphragm. So yeah, that's everything.
Wow, Shema, you're never disappointed. This is such a wonderful learning case. A very sad diagnosis for this patient as well. But thank you so much for sharing. And just to do a quick cognitive biopsy, when you first say like pleural thickening, back of my mind, the association that with step 1 that pumped up was mesothelioma, and then my brain completely dismissed it because I was like, oh, she's like 40. Like mesothelioma has a long latency period usually. So I was like, oh, I think like she would be too young for that. So I didn't even mention it, and my brain like gave it only a 2-second thought. So this is like what a really, really wonderful reminder that we don't, our patients don't read textbooks. Really, wow, I did not expect mesothelioma. Thanks for sharing this. Jack,
Yeah, thank you so much, Fema. No, this was a fantastic case. I'm just constantly humbled by the differences in data that comes to us and data that we have to go and seek out. I think that this is a great reminder that oftentimes exposure-related diseases is data that we have to seek out, whereas symptom-related diseases is oftentimes the data that may come to us in the forefront, and sort of separating that, separating the way that we think about symptoms that we may be able to ask open-ended questions, and then exposures, oftentimes we have to be targeted in doing it. And I think, Charmaine, your reflection is spot on that once we see that pleural thickening, that's the trigger to then think about the possible exposure-related diseases, in addition to the other things that we were thinking about as well. Right. Chiara, you want to take us away with the teaching points? David, thank you so much for scribing as well on this. This was a data-heavy case and a phenomenal job getting everything up there in such a concise way.
Hi, friends. Hi. Thank you, Shaima, for this, well, not that good, happy case, but a very interesting case, a very challenging one. So we started with probably pleuritic complaint. So we have a beautiful schema for chest pain, especially, and we have our no-miss diagnosis, which are for cardiac diseases, especially acute coronary syndrome, dissection, tamponade, and Tabot's disease. Also, our two pulmonary no-miss diagnoses, which are pulmonary embolism and pneumothorax, and esophageal causes, which are rupture and infection. So after a little more of the HPI, we found that this was a probably pleuritic disease, because this patient had pain and dyspnea that worsens with leaning forward, and also pain with cough, which are like pleuritic signs. Then we learned that this patient had a subacute chronic time course, but the special part was to know her trajectory of the disease, because this was kind of a crescendo trajectory. And with this, we usually have some diseases that are consistent with this time course plus trajectory, which are infectious diseases, especially pulmonary or pleural diseases, some autoimmune diseases, which are usually the pleurs that have this crescendo pattern, and some malignancies, especially mediastinum or solid or tumors that are space occupying disease. So also we learned after, with some further history, that she had some social history. She was from Mexico and she moved to the US 19 years ago. So Jack told us that it's important when we want to consider ID or infectious diseases. We have to know where, but especially when, because if this is it's been a long time since this patient moved to the US, maybe we can have the ID background like in the back, and consider other diseases. So after this information, how we moved forward, we found that she had some pleural or pulmonary pathology, and she had a large pleural effusion. So how we move forward, we should perform a pleural placentesis to rule out an exudative process versus a transudative process. Also, it is important to check if this is an isolated pleural process versus a pleural plus pulmonary disease. Then after this information, we found out that there was pleural nodularity, and CP Solvers has a very great schema for pleural nodularity. Actually, we CP Solvers have schemas for everything. So, we're talking about pleural nodularity. We have that malignancy is more common than infectious diseases or autoimmune disease. In malignancy, we usually solid malignancy or pleural, and some hematologic malignancy are can present with pleural nodularity. And when we are talking about infectious diseases, TB and crypto are the first things we can consider, and autoimmune diseases are quite in the top of our mind. And how can we make a diagnosis of pleural nodularity? First, we have to look at the chest disease. Then we have to look outside of the disease, especially to check if there are some mets. And in the third place, we have to look back at the chest. Also, in this case, there was a a quite chance of having TB. So despite she had 3 times sputum ulcers, we don't exclude TB unless there is a biopsy. So finally, this was a very sad case. It was a malignant mesothelioma, but very interesting one. Actually, Gerlin, I think a couple of months ago, she presented a cardiac mesothelioma, which is very, very rare too. And some markers that we can that can help to diagnose some tumors are that CK20 positive CK20 is it correlates with GI tumors, and CK7 are correlate with tumors above the diaphragm. So thank you so much for being here, and this was an amazing case, and of course, as always, an outstanding discussion.
Amazing, Kiara. Thank you so much for that teaching points. Shema, awesome case. Thank you for presenting. Learned a lot. Hope the patient did okay. Fingers crossed. David, thanks so much for scribing. Kiara, teaching points. Jack, my co-pilot, and everybody else. Thank you all. This was full of learning, much to reflect on. Bye, y'all.